Queridos amigos, hoy estamos haciendo tendremos una conversación muy especial con Suzanne O'Sullivan, que es una neuróloga y autora de este libro que os enseño aquí, tan chulo, tan guay, que es Todo está en tu cabeza, ¿no? Es un libro súper interesante del cual vamos a hablar con Suzanne hoy y que trata. Os hago un resumen muy conciso. Este libro trata de su experiencia clínica de muchos años con casos de epilepsia especiales, porque eran casos en los cuales eran mentales, ahora lo hablaremos con Suzanne, eran psicosomáticos, y ella habla de esos increíbles casos, ¿no? Entonces, creo que esta conversación nos va a ir muy bien porque vamos a hablar en general de la psicosomática, ¿no? De los dolores de cabeza psicosomáticos, dolores de espalda psicosomáticos, la fatiga crónica, el dolor crónico y tantísimos otros síntomas que los seres humanos experimentamos que en realidad los produce nuestra mente, aunque parecen problemas físicos, fisiológicos, etc. Entonces vamos a pasar a hablar en inglés con Susan. Susan, I did a brief introduction. Did you understand something?
Oh, I caught a little bit of it, but if I didn't know what the subject matter was, I would not have caught much.
Okay. What I said is that you are a neurologist and that this book, that is awesome, is lovely, treats mainly about these cases of epilepsy that you treated during so many years, that you realize that they were mental. The person didn't have any physiological problem, I don't know how to say, and you talk about this topic, and I said to the audience that it can be a great example, not only about epilepsy or pseudo epilepsy, but all the other problems that are psychosomatic, all types of pain, fatigue, and many other problems that people are suffering today. Am I correct in the more or less in the summarizing of this book?
Yeah, it's you are correct, except to say that it's a great example of how sort of language fails us with these disorders. So obviously we both have a different first language, but even within English speakers, if that's your first language, it's so hard to put words to these medical problems, to explain them in a way that legitimizes the suffering and helps everyone understand what we're talking about. So this book is about my patients, not my patients who came to me believing they had epilepsy, but who transpired not to have epilepsy. And you use the term pseudo seizures in this in your introduction. And again, that is what they were called for many years. So these are people who have seizures that look like epilepsy, but actually they're not epilepsy. They're sort of they have a psychological cause. And for years, until I was a qualified consultant, so until the end of the 20th century, we call these things pseudo seizures. And it's just interesting to think about that word, because you're pretty much saying to patients, if something is pseudo, it's like you're pretending or you're putting it on.
Right.
And I think for 100 years, people were pretty much saying to patients, either you have epilepsy or you're pretending to have epilepsy, with that language. But we're still sort of, in the medical world, still trying to find language that doesn't kind of lessen the suffering of people who have these problems, because they're very serious problems.
But how would you call it?
So the latest listen, the name changes all the time, and I slightly have a problem with that. The current name in neurological medical circles are dissociative seizures. So they're sort of saying these are seizures that arise out of the psychological sort of out of dissociation, which is dissociation being something that, you know, is a normal part of life. We all dissociate from time to time in that our minds kind of wander away somewhere, or we miss a few seconds of a conversation. Obviously, dissociation for some people is really problematic. It causes psychiatric problems, but it also causes seizures. So we now very often call them dissociative seizures, although there's already a sort of a movement to calling them functional seizures, to move the whole thing away from psychology completely, which I don't agree with. You know, these are arising through a psychological mechanism. But it's just evidence that when I started out as a doctor, they were pseudo seizures, then non-epileptic seizures, then psychogenic non-epileptic seizures, and dissociative seizures, then functional seizures. And what this is evidence of is that we're trying to sanitize a conversation by choosing a name that's palatable, rather than explaining to people what we're talking about so they understand it's not a medical disorder that anyone should feel ashamed of.
It's true, it's true. Later we will talk about this, no? The problem that arises when the person feels that what happens to them is denied, or they are pretending that they are inventing for some reason or whatever, which is not the case at all. Yep. But we will talk about this a bit later. But first, I would like to ask you if you can explain us what were those cases? What happened to the people that you saw at your office?
Yeah, so a really typical example would be somebody who, for example, this often is it's a disorder affects anybody, but young women do tend to be more affected than other people. Mm-hmm. So a really typical example would be that, you know, a young woman in a hot, sweaty environment like the London Underground is very overcrowded, or sometimes it happens in churches or in schools, but hot, sweaty places, a young woman faints. Now, what happens when most people faint is they don't realize it, you know, a lot of people shake and they go rigid and things. So that's very easy to mistake for a seizure. And that's often how these things begin. They begin with a medical problem, which is just a straightforward medical problem, or it could be an injury like, you know, you injure your foot and then you're having difficulty recovering from it. You faint and that unleashes a sequence of events. But once something happens, like somebody faints, it can set off a chain of events that every time you feel a little bit sick, or every time you're in a situation where you previously fainted, you then collapse and have a convulsion. So I was seeing a lot of young people who started having regular convulsions, starting with maybe an inciting incident like a faint. And because people don't think that every time someone collapses and shakes, it must be epilepsy, those people are diagnosed with epilepsy, and they come to me in my epilepsy clinic thinking they have difficult to treat epilepsy because it's not getting better with medication. Yes. And some of these people, I should say, are really, really sick. So I'm seeing people who are maybe having seizures, falling on the ground and having a convulsion 20 times a day or 20 times a week. So very, very disabling. They've been diagnosed with epilepsy elsewhere by people who don't fully understand epilepsy and put on epilepsy tablets. They're not getting better. They come to me because they think they're going to get even better treatment for epilepsy. Yes. What actually happens is I listen to their stories and I look at their seizures. I know what epilepsy looks like and how it behaves. And I can see these people do not have epilepsy, because actually about 1/3 of people, if you've got 10 people in an epilepsy clinic having seizures, 3 or 4 of those don't have epilepsy. 3 or 4 of those, that
amazing number.
So common. Yeah. And it's sort of, so about a third of anyone who comes to my clinic, their collapses are happening for purely psychological reasons.
Yes.
And sometimes, and you call those pseudo seizures, I call them dissociative seizures, other people call them non-epileptic attacks. A lot of people misunderstand what they are. They think it is purely a disorder that happens, you know, at the moment of psychological stress. And absolutely, they do happen at the moment of psychological stress, but they also can happen for lots of other reasons, because a pattern was set up for perhaps with a frightening fainting episode that
Yes.
creates an expectation from one's body, or because one has seen a lot of seizures and therefore one has certain expectations of what
Yes.
happens in certain situations. So I see a lot of people who come to me thinking they have epilepsy, and I have to say to them, you know, I don't think this is epilepsy. I think this has a psychological cause. And you can imagine how difficult that is to hear.
This is the second question I wanted to ask you, because this is a very, very interesting thing, very important, because many people, I
yeah,
would say most of the people
yeah,
that have psychosomatic problems, I wouldn't say illnesses because it's not a physical illness,
yeah,
but psychosomatic problems, for them is very shocking
yeah.
when you tell them that their problem might not be a physical problem. You have seen this a lot.
Yeah. I mean, again, this is where language fails us, isn't it? Because not just within the English language, we're saying it's not a physical problem. Well, if you're falling on the ground and shaking, it is a physical problem. I understand what you're saying, but this is why it's so hard to explain these things, you know, and why it's so hard to treat them. Because if you have a disability like being unable to walk and collapsing, it is a physical problem, but it's not due to a brain disease, which is the distinction. But you're right. When a person comes to clinic, they really have struggled with the diagnosis for two main reasons. One is they struggle to believe it's even possible. So, you know, we all are a little bit aware of the mind-brain connection, mind-body connection in its smaller versions. Like we know if we're frightened, our hearts go quicker, or we know if we're nervous, our hands shake, and we know if we're upset, water comes from our eyes. So we're aware that there is this mind-body connection, but most people aren't aware how far that can go, that it can lead to complete paralysis of your legs, being not able to move, complete blindness, deafness, seizures, memory loss. So people are a little bit shocked at the extent of it. But the main reason people struggle is they realize the minute they're told this isn't epilepsy, or this isn't multiple sclerosis, or this isn't a brain disease, this is psychosomatic, they feel that their diagnosis has been immediately downgraded.
Yes.
It's like their seizures are less severe, or their paralysis isn't as disabling. And you know, they're right to feel that way, because you know, you can imagine if you went to your employer and said, well, I can't work because I've got, you know, paralysis due to multiple sclerosis or some brain problem. And then a week later, you go back to your employer and say, well, actually, it's not a brain problem. It's mostly a psychological problem. You can feel how people's attitudes change with that, because we just do not respect psychological kind of suffering as much as
Absolutely.
related suffering. So people really struggle with the diagnosis, and I totally understand why. They're justified in that.
Absolutely. But there's it's such a pity that many people in many psychosomatic problems won't treat their problems correctly, and they will go on thinking that they have a hidden disorder that nobody knows what it is. I'm talking about, for instance, fatigue syndrome, the chronic pain syndrome, and all those cases that they don't wanna consider that the mind does those things all the time. It's not of the strength. So for me, as a professional of this, it's a pity, because I see clearly, in my opinion, that what they have could be cured with another approach, and they don't want to see it. That's it. Have you felt that?
Oh, I 100% agree with you. It's the shame of it. If you could just, and people are, no, it's precisely, people find it easier to think it's a disease no one can find, or it's a mystery illness, than to accept this psychological explanation. And patients will go for a scan, another scan, another scan. I can offer them tablets that are experimental and have horrible side effects, and they'll take them. I don't do that, but I know if I say, well, take this drug or that drug or have this scan, that people will agree to it, because they're so invested in the concept that the only thing that can be caused by this is a disease. So I try to say to the patients, because I feel as you do, isn't it, it's such a shame you won't even explore this avenue. I try to say to my patients, you know, if you get to a point in your medical journey where you're just having lots of scans and taking lots of tablets and absolutely nothing is making you better, now perhaps you're not keen on, you know, or you can't quite relate to this kind of psychological formulation. Why can't you apply the same sort of attitude to that as you would to another scan, which is basically, you know, you're willing to have another scan. Why not try this? If you'll try anything, why not try this? And that works for some people, but, you know, unfortunately, the shame attached with psychosomatic illness makes it difficult for people to get as far as people like you, which is just terrible. Yeah.
And isn't it, Suzanne, isn't it so surprising to you? It is to me that the mind can produce such an array of illness, of symptoms, such an amazing quantity of amazing symptoms.
Yeah. I mean, I suppose it was probably a surprise to me 20 years ago, but at this point, there is nothing I haven't seen. I will believe anything. And I'm beginning to be better at holding, you know, people really don't understand that our body is the mouthpiece of our minds, and our, you know, every thought you have and every sort of emotion that you experience it with your body. I think people sort of think of thoughts as being sort of something floating around in your head. But actually, you know, if you look around a room full of people, you can say, well, he's confident and, you know, she's shy, or he's happy and she's sad. You know, you can even see cultural differences in the way people carry themselves. You know, we reveal ourselves through our bodies. So for me, also, you know, what helps me also with the concept is that I'm extremely aware of the fact that I am a completely, you know, I experience all my sort of anxieties through my body, you know, all the time. Sometimes when I have to speak in public, you know, my voice really shakes quite badly. And once I did a book tour in America. Now I'm a doctor. I don't do book tours. You know, this is exceptionally unusual thing for me. And just before I flew to America, I guess I was pretty scared. I got a cold and I lost my voice. And when I got to the States, I had to do loads of radio shows and things. And for the first 24 hours, I couldn't speak at all. And I suspected it was anxiety related, but I walked into the very first radio interview and the interviewer asked me a question and my voice recovered like that because it just had to. So I'm aware I am a person whose anxieties come out in that way. So I guess that helps me to not be like completely shocked all the time that these things are possible, you know.
Later, I might explain you what I think is an incredible experience that I had myself.
Really?
I had myself because I had I don't know the word in English, lumbalgia.
Yeah. I know what you mean. Lumbago, we would call it. Like low back kind of pain. Yeah.
This is lumbago.
Lumbago.
I had this for, I would say, 25 years.
Yeah.
Since I was 20, since 40 something. And then I realized, you believe it or not, that it was mental.
Yeah.
That this blockage that I had in the back wasn't real. And then I stopped having it.
Yeah, I know. Because these things are sustained. I mean, first of all, this is a really important part of the conversation, because the minute you start talking about these things, you realize that everybody has one of these experiences. And I think that's important for people to know, because I think sometimes people with psychosomatic disorders are sort of considered to be weak or fragile or mad or, you know, attention seeking. But this mind body thing is just ordinary, and everyone has it, and some people have it worse and some people have it better. but also the thing about, you know, my losing my voice in this anxious situation, or you having this pain in your back, is one of the things that sustains these symptoms is the attention that we pay to them and the way we change our lives to accommodate them. So, you know, the minute you find your sort of way of paying less attention to something and being less aware of it, you know, because often, you know, we don't use our bodies normally if we're protecting ourselves from some medical problem, and that can exacerbate the problem. So sometimes we just need something to break that kind of cycle of anxiety and attention to get better.
Exactly. In fact, my approach as a CBT therapist to these problems are double. And the first movement is to try to convince the person that surely she has not a medical problem. Examples of other people that have the same. We analyze the how the problem goes and the poor logic of the problem when you can see it. No, you might have migraine only on the weekends. How can you have a disability that knows the calendar? It's very strange, because I mean, if you've got a real problem, my body doesn't know the Roman calendar.
Yeah.
This is very strange.
Yeah.
And so the first thing is the people to consider seriously that might be not a medical problem. And the second is to contradict the symptom. For instance, people with migraine that has associated, for instance, sunbathing with pain, or drinking wine with having the headache, or not sleeping in the night and the following day having the and then we say, okay, do that and try to experience that it won't happen someday. And then you will see that it's an association. Because those associations are very important. Or in the case that you said before, if I go to the tube underground, it's hot, but I say to myself, I don't have to faint. I fainted in the past, but I don't have to faint. I'm gonna talk to my friends. I'm gonna make a joke. I'm gonna distract myself. I'm gonna talk to my relative for a while and forget about this. And then the association breaks. And the mind of the person thinks, it might be right.
Yeah.
I might be okay.
Yeah.
And then...
And it's interesting what you say, because, I mean, that's exactly, I tried, because I'm sure you might tell me later, but waiting lists for CBT in Spain are probably, I mean, in the UK, they can be really, really long. Yes. So often in clinic, I will try and do sort of my sort of kind of layperson version of CBT. Right. But it's a similar sort of thing. It's, you know, you're in this situation, and then we just ask people to distract themselves with, you know, pay attention to certain sounds or how your clothes feel, etc. But and I'm sure you experience this, is what's amazing is how quickly that can work sometimes. Yes. So sometimes you can just have one conversation with somebody, and as soon as it's at some level, even if they don't really agree with me about the diagnosis, at some level a fear has been allayed and attention has been taken away from the body. And about 30% of patients, even those with having seizures every day, after one conversation, the seizures can just go away. And so I'd say to anybody, because I think it's likely your audience already is psychologically minded, so they may be slightly a different audience, but there is a lot of people don't really believe in this mind-body connection, and they should experience that the power of one conversation to make people better, and that they will be converted, I guarantee you.
Absolutely. It has happened to me, that I'll tell you, people listening to this conversation, some people, a percentage, will stop experiences fatigue syndrome, pain, chronic pain, and other things just in one conversation. They can see. They write to me after a time, and I'm always amazed of those.
I know. And I think it's also good for doctors to understand that, because, you know, I think doctors have been generally disinterested in these problems. Yes. You know, these are the kind of patients that doctors kind of say, oh, it's, you know, it's not real in some way, and therefore I don't care as much about it. You know, I'd say to doctors that this is an opportunity to be your personality and your skill as a clinical doctor has the power to make people better without any of the fancy sort of medications or scans or anything else. And, you know, you think as a medical student, you think, oh, it's going to be so exciting, you know, blood pumping everywhere and everything. But I would say to you that I've never experienced anything as satisfying as the possibility of having a really great therapeutic conversation with someone that explains their symptoms to them and demystifies it and destigmatizes it. And the next day, just through that, they're feeling better. And you're like, that is rewarding as a doctor.
There's some authors, the researchers in the topic of pain that affirm that half of the back problems that even get an intervention, a surgical intervention, in reality, don't need it.
Yeah, 100%. I mean, I'm no expert in back problems, but that does not surprise me at all, especially when you think of people are too trusting in things like scans, and very not trusting of people like you and I sometimes, but terribly trusting in things like scans. I mean, if you scan any person, you will find some wear and tear or disc out of place.
Many.
It's so easy to then follow that route to surgery. And I think an awful lot of intervention happens that really doesn't need to happen.
And you're a neurologist, Suzanne. What do you think about migraine?
Well, I think that, you know, we tend to make a big distinction between different sorts of headaches. And, you know, when we as neurologists diagnose migraine, it's a very specific characteristic of headache, of a particular type of headache that comes with a constellation of symptoms such as light sensitivity and noise sensitivity. So it tends as to a neurologist, a migraine is a very specific headache. But I find that people are told they have migraine by people who think that the only thing a migraine is a bad headache. You know, but there's lots of you know, muscular headaches that are like tension headaches and stress headaches that are called migraine because they're severe. So I think migraine is a discrete condition, but a lot of people are told they have migraine that probably don't. And it's, you know, I think only really neurologists and headache specialists are able to make the distinction between the two. So I suppose what I'm saying is a percentage of people who've been told they have migraine probably have more of a psychosomatic headache, in my view.
But some authors, I'm not a neurologist, so I don't know, but some neurologists, especially there is one in Spain, that affirms that at least a good part of what is thought to be a migraine, with all the symptomatology of a migraine, in reality, there's nothing wrong at a physiological level. And the proof of this is that this group of doctors treat them.
Yeah.
And I show you, Suzanne, I've seen many cures.
Yeah.
Without medication, only with as a psychological intervention. What do you think about this?
Actually, I'm not going to claim to be an expert in migraine, but I wouldn't disbelieve that I wouldn't, you know, I think that it's entirely possible that a large number of people who've been labeled with migraine have more of a psychosomatic problem. I think that it's quite interesting when you look at treatments for what is labeled as sort of legitimate migraine per se, and they are uncannily similar to how one would treat a psychosomatic problem. So, migraine clinics very often treat people with lifestyle changes and psychological input and call it migraine.
Antidepressants as well.
Yeah, sorry.
Antidepressants as well.
Yeah, I think it's interesting. I think that there's a real muddy area there. I think there probably are some people with migraine where it's mostly vascular, but I'd imagine there is a large number of headaches mislabeled as migraine, and certainly there's a large psychological factor in migraine. And again, so it should just be a useful thought to people, which is, do I want to load myself down with all these medications that cause risks in pregnancy and side effects and drowsiness? Or would I like to consider lifestyle psychological interventions before I do that? It just opens up new ways of approaching it. So if I were a person, I don't have migraine, but if I did, I would probably prefer to take the non-medical route first.
So that's another topic. It would be, I have this thinking sometimes that if the mind is so capable of constructing this kind of symptoms, it can be very good as well. It could be very good as well to construct. That's the opposite. I mean, so the power of the mind to construct not only our moods, which is my main thing, but also things like feeling strong, awake, on the mood of doing the different things. I think there is in reality, I think many times I think that we still don't have all the tools to modify, to intervene in this capability of the mind. But seeing all those things, my reflection is that, wow, there is an incredible power in there.
Yeah, I mean, I think that first of all, Freud said instead, I'm going to misquote Freud, but or it might have been Breuer in Studies in Hysteria, which was the sort of 1916 sort of book on this. He said, if a thought can trigger a movement, why shouldn't a thought hinder a movement?
Yes.
And that's precisely what you're saying. But I think, it's if you want to look at the power of so what happens to our bodies, every movement we have and everything that we experience in the world is just a construction of our experience. Our mind is programmed with expectations of how the world should behave that we've been learning since the day we first tried to stand up and walk and we fell over.
Yeah.
So if you look at movements as an example, so we all walk around every day without thinking about it because we've been doing it seamlessly for many, many years. But if you then ask somebody to walk, a straight line, sort of one foot in front of the other, or if you ask them to walk on the edge of a cliff or at the top of a high wall, suddenly everything about your movement changes. Yes. So all you have to do to change a person's physical well-being is to change their circumstance, or to make them think about their body differently, or to put them in a position where they're fearful for their safety. And suddenly something they could do with their eyes closed, they can't do anymore. So you can change somebody's movements so easily. I understand that when men try to empty their bladders in public urinals, that, the bladders won't empty. Or if you ask a footballer to kick a penalty kick in front of a crowd of 10,000 people, only some footballers can do it. So, there's just an endless number of examples of how we can kind of disable our bodies by our circumstances, by thinking about it differently, by being frightened. So I think that this kind of assumption, we've got a kind of weird assumption that we're in control of ourselves all the time, and that everything we're doing is deliberate. I think people know in kind of psychological medicine, people understand that, you know, some of the things that upset us aren't necessarily about what's happening now, but it's about something that happened in the distant past. It's exactly the same with our ideas about movement and sensation and our experience of the physical world. It's all to do with our expectations and our situations and our circumstances. So if we are, do you know what? I'm going to say it more succinctly. If you can learn to do something, why is it, you know, so example, if I can learn to play tennis or I can learn to walk, why is it not reasonable to think that if the circumstances are right, I could unlearn it? Yes. That I could, you know, that something changes slightly that makes me worse at something instead of better at something. So when we encounter people who've got complete paralysis of their legs and you talk to them about how it happened, it's usually quite obvious. You know, something happened to make them more aware of their legs. They started focusing too much attention on their legs. You don't pay attention to your body. Once you do, it feels strange. Then once it started feeling strange, they started doing less and their body deconditioned. And essentially through a process like that, you just unlearn things. And that's how these disabilities develop. And it's quite normal.
Absolutely. Well, Suzanne, it has been a great pleasure to talk to you for a while. We are gonna, I'll say something in Spanish before we end. This is that este es el libro de Suzanne, este es el primer libro que publicó Suzanne O'Sullivan, Todo está en tu cabeza. Tiene otro libro publicado en español que no lo he conseguido para esta conversación, pero que se ha publicado hace poco. Your last book, what is the title?
My most recent book is called The Sleeping Beauties. It's also about psychosomatic illness, but told through stories of mass hysteria outbreaks around the world.
Ok. O sea, el segundo libro se llama Las bellezas escondidas, sería el título. Ya os diré cómo es el título en castellano, ahora no lo sé. Y con esto despediremos a Suzanne. Ha sido un placer hablar con ella. Suzanne, it has been a pleasure.
Thank you for having me.
Thank you very much for this talk and these incredible books that are so important that people know that things happen. And yeah. Just in case it happens to us.
Thank you for your interest and thanks for the great work you do as well. Thank you.
Thank you.